So what I'm going to look at today is basically trying to understand if CBCT is really an essential diagnostic tool for current dental practice. I personally believe yes, it is essential. But let's take a decision towards the end of this lecture. So I'm only going to look at a few things today. One is a historical perspective. I very strongly believe a machine that you use, you should actually know how it works. We aren't really technicians there. We are diagnosticians. So it's our basic right to understand. I think it's also a duty to understand how this machine works. A little bit of basics of digital radiography. I'm honestly not sure what's the audience like today, but I'm assuming many of them practitioners, probably a couple of them working in Sharavati Dental College, probably practitioners and students probably. So if you are practitioners with vast experience and also practitioners with already CBCT knowledge, I guess you just have to sit back and then wait out for your lunch. For others, I want to take you back, trying to jog your memories, take you back to dentistry. If you remember the final year in BDS, we look at digital radiography a little differently than what it was taught many years ago. Then, since we've all been used to panoramic radiograph, let's look at if this is still relevant today. A little bit on 2D versus 3D. Then, since CT is typically the known gold standard for 3D, let's look at how CBCT would compare with CT. And an understanding of CBCT, I think we should know anatomical landmarks. So I'll probably delve a little bit there. And then, of course, we'll answer that quintessential question on, is it really essential? Is it a diagnostic tool? So we'll do all that today, right? I'm not sure if a couple of you can unmute if you want to, but I love to start this lecture always with this lady. She said, I have seen my death. I'm not sure if a couple of you can unmute if you can. Dr. Akshita, if you want to go, have a go. Do you want to just guess? I'm sorry, I'm asking questions.
Sorry.
Yeah, Akshita, want to guess?
No, I'm sorry.
Okay, no worries. Yeah, no, it's okay. Normally, what I hear is Madame Curie and all that I hear most of the times, but this lady is the typical lady behind the great man, and now would know, right? We know this man, Wilhelm Conrad Röntgen, the great physicist. And for me personally, I believe there are two major years in radiology, the landmark years I call it. One is 1895 when X-rays were discovered by this gentleman. And then of course, now you see that the finger ring, now you know that lady, Anna Bertha, his wife, okay? Of course, and then let's go to this. This is again, very popular images, at least the one on top, we all have seen this image multiple times, especially ones that come out during those typical antique car rallies that we are aware of. That's that's the Model T, the Ford Model T. That's typically, like I should say, the Maruti 800s of today. Literally everyone had those Model Ts then, those back of time, and at that point of time. And then of course the one that you see down below, the Ford Mustang, literally the fastest car around now. And why am I teaching about Ford today? That's because of, again, these three gentlemen, Feldkamp, Davis, and Kress, and mark the year 1984. I personally believe, again, this is the second biggest landmark year in radiology. And why FTK? Because that's called the FTK algorithm on which the CBCT is literally based today. All the machines that we have today have this backbone of this cone beam algorithm proposed by these three guys, Feldkamp, Davis, and Kress. And why Ford? So essentially these guys were actually mechanics working in the Ford company in America. They wanted a way to look at some kind of, should I say, core porosities, fractures within nuts and bolts. So they wanted some kind of way, a non-destructive method, rather, I should say, a non-destructive method to look at these. And then they began talking about this back projection and then came out the practical cone algorithm. So that's the fundamentals that we should know. And of course, then based on that principle, much before this, it was used in angiography. And they, way back in 1999, I should say about 2 decades ago, the first dento-maxilofacial CBCT unit came out. This was by Newton. And then 2001, the Japanese came with Akitomo. And then now you should know they're close to, should I say, 47, if I'm not mistaken, 47 CBCT machines made by over 20 companies presently. So in about 2 decades, we had this huge explosion of CBCT machines staring at us. Now, when we're going to get into CBCT, it's always nice to know what's digital radiography, because when you talk of CBCT, it's not just 3D, but we are moving away from plain film radiography to digital imaging. So let's go to some concepts on digital imaging, because like I told you, it's nice to always know the kind of machines that you're handling. So there's no big difference between what's digital and conventional imaging. In a conventional imaging, all you have is you have the detector that you have, the film, the typical IOPR, the intraoral film that you have, that is both the detector, it detects, and it also stores information. Whereas in digital detectors, the detectors separate, and then you have to store it on a digital medium. That's only the biggest difference. And of course, when you use a digital imaging, there are many, I mean, there's nothing to be ashamed of. A lot of people believe that the X-ray tube is slightly different. Literally, the detector is different, but the tube is generally standard. It's the same across all machines. The tube is standard. Only the detector keeps varying. And then, of course, these electrical impulses are recorded, digitized, and that's called sampling. For every, should I say, every electrical charge that is produced, there's a grayscale that is given, and that is stored as a digital image. That's called sampling. And most importantly, you have a post-processing software that actually converts all this raw energy into some kind of a data. Okay. I just love this flow chart. If you look at this concept of digital radiography, in academic settings and clinics, you must have heard people talking of, do you have a CR or a DR machine? Honestly, a couple of decades ago, I used to wonder what the CR and DR really meant. But if you look at the CR and DR images, it's simply CR is computed radiography and DR is direct radiography. Today, as we are here on this webinar, when we talk about CBCT, we are right down here. We are talking of something called FPD, or flat panel detectors. So if somebody says, what kind of radiography are you dealing with? You can say, I'm working with direct radiography using a flat panel detector. Okay. Now, what's the basic difference? Nothing bad with the CRs. Now, people who are into 2D really, who are into 2D, the typical machines that we take panoramic radiographs with, if you want to really move to direct, I would say a CR is slightly an in-between step. How's it in between? We look at it now. So in CR systems, what would happen is you have a phosphor plate that looks typically like your panoramic film, the typical 5 by 12 watt film. You have an old 2D cassette. You place the CR phosphor plate within, close the cassette shut, and suddenly your machine now is behaving like a digital radiography unit. You have a digital radiography unit. But then that's only half of the story, because you have information here in this cassette. If it was standard 2D, what you would do, you would walk to the darkroom, process the film. But in a CR, you need a scanner. So you take the phosphor plate, go to the scanner, and the scanner would give you that output, the image. So that's a CR system. So it's a simple conversion of a 2D into three-dimensional. Whereas in a direct radiography, we'll come to that now a little later. Let's look at CR a little more. Nothing wrong with CR, I would say, and as some of the institutes that have CR units would know, that the biggest advantage, apart from telling you that it is easily integrated, the other biggest advantage you get with CR machines is something called a wide dynamic range. Now, when we had to buy machines, we had people coming talking to us saying, hey, so this machine has a wide dynamic range. I literally wondered what that meant. So with a CR machine that you really don't get with direct, you can get close to a wide dynamic range, but this is term you all have to know. When you say wide dynamic range, it means for every object, when light shines on it, you have a highlight that is the brightest area. You can see the picture there. And then you have a shadow, the core of the shadow, that's the darkest area. So when you say wide dynamic range, it tells you that it gives you a lot of gray scales. So I'd love to have this machine when I'm probably interpreting periodontal disorders or periodontal diseases rather. So I'd see bone, I'd see cementum, I'd see a bit of soft tissue areas, the periodontal ligament space. So that wide grayscale that you get only with CR systems. So if you're falling short with other machines saying, hey, I'm not able to see a lot of grayscales, that's okay, because that's the limitation. Whereas with a CR system, it's wonderful. But one big problem with CR is noise, radiographic noise. You must have seen PSP systems having a lot of grainy areas. Those typical grains that you see is radiographic noise, and that's that's, should I say, one of the characteristics of CR machines. Hence, the need to switch over from a CR. And then came up CCDs. You remember the RVGs that we had? I'm sure some of clinics would still have RVGs. Some panoramic machines have not a film base, but have a CCD sensor. That was the second generation, I would say, when you shifted over from CR and went to RVGs. It's great. RVG gives you a better image quality. The CCD sensors give you better image quality. And here what happens is you don't have just X-rays that are interact with the phosphoplate, but you have light that will interact, and then there you get it captured as electrical charges into the CCD. Okay. Now here, what was used is just scintillators to create that light, because X-rays will cause light, and that is in turn converted electric charges, and then there's a readout process. With digital direct radiography, that is a direct conversion, what we are all talking today about CBCT, please note they're all flat panel detectors, and these are all made of a material called selenium. And why selenium? Selenium by itself has something called, I should say, a very inherent property of having good spatial resolution. When I tell you, maybe a little later on about resolution, I'll come to it. So essentially, what you're doing is replacing the CCD. I mean, no more CCD, but you're going ahead another new technology referred to as thin film transistors with a photoconductor. And the photoconductor in this case is selenium. So when you talk about CR, it has phosphoplates, when you talk RVGs, and they're mostly with CCDs. And finally, when you're talking about CBCTs, you're talking about thin film transistors along with a photoconductor. So I mean that's the whole way it plays around. Okay, I think we should let's stick here. Yeah, so when you use these photoconductors with thin film transistors or TFT arrays, that's what is CBCT machine, the PDs, the flat panel detectors. You should always know that all of these come with an image processing software. And usually when the machines are there, they come with their own software. It cannot be replaced by another software. So each machine comes with its own software. Right. So with that basic background, there are just 4 other new terms are introduced to you, and then you guys are all set to deal with CBCT. Some things you should know are something called a pixel size and matrix, a spatial resolution, dynamic range. We looked at, I guess, dynamic range already, the wide dynamic range that is showing you all a lot of grayscales. And finally, something called DQE or detective quantum efficiency. Now, let's look at pixels. I told you there are like 20 odd, 47 odd machines with 20 odd manufacturers. Generally, all of them pitch in there. All of them have the same configurations, one doing better than the other with small differences. But if there's a shortcoming of the image, then these are 4 things you look at. One of them is pixel. Now let's look at the last point there. So all of you, I'm sure by now know what a pixel is, just a picture element. It's a digital image, one small element of picture. Now what's important here, for you to have that great spatial resolution, you should have small, tiny pixels. The smaller the pixel, wonderful for us. But these pixels should be on a wide array, a big matrix. So the larger the matrix, but smaller pixels. So this matrix should have like 1056 into 1056, or as many pixels as you want. The more you have, the more merrier, the more better is spatial resolution. I have a slide. Yeah, so I'll come to it now. So we've understood this concept. So what you're looking at in a machine is, does it have small, tiny pixels? The more smaller pixels you can go to, and I mean, when you talk of 3D, you go to voxels too, but the more tiny the pixels are, better for you. And bigger the matrix, that's what you want. Second, spatial resolution. We looked at pixels. Second, spatial resolution. By default, I told you, selenium by itself has great spatial resolution. So nothing to really pick and choose here. Most of the machines that come have great spatial resolution. So because they use selenium. Of course, you could tweak a little bit here and there based on, when you use software, this whole spatial resolution itself cannot be changed specially, but the image quality can be manipulated a little bit with the software. Now, all you need to know is, if I can spend a minute here very quickly, when you talk of spatial resolution, if you go back to 2D, since you're comparing 2D and 3D here, if you have to go back to 2D, way back in dental school, I'm sure somebody taught you about something called line pairs per mm. It means, if you look at your, if I recollect my days of math in school, you had that small tiny graph sheet, the 1 square centimeter, and within which again you had those 1 mm lines. So if you have to look at something like that, when I talk about 2D, just to give an example, if I'm looking at, say, intraoral periapical radiographs, the small film, the 31 into 41 mm film that we all held in our hands at undergraduate students, that film itself, the resolution for the IOPA film is roughly about 18 to 20 line pairs per mm. It means in 1 mm, this intraoral periapical can see 18 line pairs, 2 lines. How close? Can you see those 2 lines together? Like that, 18 or 20 in 1 mm. That's what an intraoral periapical can see. And how about our the beloved panoramic radiograph? The pan can see roughly 8 to 10 line pairs per mm. That was 18 to 20. The pan is 8 to 10. It means the pan is pretty blind. It can't see much. Hence, we say, not good. The pan is not too clear. So then we go back to IOPR, right? The intraoral periapical, because it gives you more finer details. And how about the well-known, the renowned CT that we all use? CT been used for about 4 decades now, the CT scans. The CT scan, it's roughly like the pan, 8 to 10 line pairs, but mind you, 8 to 10 line pairs per centimeter. So it's not mm, it's a centimeter. It can see 8 to 10. So CT is literally blind. So you would not, hence, you would not take a CT to look at root canals, but you'll still stick to intraoral periapicals. Hence, you will not take a CT to look at periodontal ligament, sorry, not CT, a pan for a periodontal ligament space assessment. Why? Because it's blind. You'll again go back to intraoral periapical. So to match with that kind of spatial resolution, CBCT does great. Okay, so if you look at 3D, you will not use these terms like line pairs per mm, but on a conversion scale, you change that to cycles per mm, and most of the diagnostic range is roughly 0 to 3 cycles. Forget these numbers, but just to let you know, CBCT is pretty good. The resolution, I should say, is pretty good to see a lot of things. Okay, and then we looked at dynamic range, showing right from bone to soft tissue, that we understood. One last point here before we move further. So we looked at pixels, we looked at spatial resolution, then we looked at wide dynamic range, we mean showing soft and hard tissue together. And finally, this is all we all need to worry about, is detective quantum efficiency. Like Dr. Shileka was mentioning earlier, we need to do a lot to our patients. We need to be really mindful of their needs. And this is where DQE comes in. What is DQE? When you say detective quantum efficiency, it means if I have a single incident X-ray beam, X-ray photon, this should be converted to an image. It should not be lost somewhere in way. Just to give a perspective, if I have 100 photons coming in, all the 100 should give me an image. No loss. If I have 200, I need 200. If you can do that, then you'll say this is an ideal detector. This has a DQE of 1. Means all the radiation that you use is converted to image. Nothing is lost in the terms of getting absorbed in the patient's body, and that is bad. So, but that one is pretty, should I say, very hypothetical. It's a wishful number, but majority of the detectors we have today are roughly between the range of 0.45 to 0.5. It means like 50%. Most of them are there. It's practical to get that number. So what this means to the patient is, if you have a lower DQE, means the patient is getting more exposure. So you're trying to aim for a high DQE, right? Yes, so that's done, I guess. So just in summary of what I discussed in the last, I should say 10, 15 minutes or more, I'm not sure, is selenium-based direct conversions DR systems. All flat panels are. You should know that small pixels and large matrix improves the spatial resolution. FPDs have a high intrinsic spatial resolution. It's very useful to have wide dynamic range, and the high DQE is always good. That's what's all about here. So we can move on now to my second section on panoramic radiograph. If I can just come in here. Dr. Akshita, are you around?
Yes, sir.
Yeah, going okay with time, or it's too, I can go on?
No,
Continue.
sir. It's
Right?
perfect, sir. It's
Yes,
perfect.
please let me know if I'm stretching it too long and you can cut me short.
No, sir. It's perfectly fine.
Yeah, thank you. So next, move on to the next concept for today's talk on panoramic radiograph. We are not going to CBCT still. We are still with panoramic now. The question to be answered is this panoramic radiograph relevant? Should we still take it? Very honestly, even today, I should very shamelessly tell all of you, even today, I like to look at my pants. I like it somehow because it's giving me that screening image. It's a good, nice screening radiograph. It does. I have a CBCT, but still I'd say, can I see a pan once? The CBCT machine does give you a better pan than this, but still, I mean, as academicians, you want to hold that film, right, somehow. So, but is it relevant? Let's answer that question. So that's a good pan. But many of us, I mean, even probably when I did my master's, and then I just realized over time that pan is great, but the problem with pan is beyond the apices of the maxillary molars, it's really not within the focal trough, it's blurred. So the apex is cut off. I mean, should I say above the apex? I see a lot of clinicians looking at pan for sinus. It's actually not fair because it's distorted. So don't even look there. We also are taught at school that the the midline, the midline portion should not be looked at for diagnosis because it's the superimposition of the cervical spine. We're also taught the canine premolar region, there's the bend of the arch, there's a curve, that's not again diagnostic. And finally, we are taught in school that pan comes with magnification errors. So ultimately what you're looking at literally in a pan is a couple of molar teeth, here and there. So then you wonder with these doubts. And every time you have a pan, there are like a million doubts that come in. Hey, what's that? Is it okay? Looking different here. Yeah, looks like elongation stridobrosis, but is it there really? What's that kind of small calcification there? Is it normal? And then, hey, this follicular space here, is it a cyst? How about this fellow here, the flame-shaped radiolucency? Is that a cyst too? And then, hey, how about this big radiolucency here? So more than giving you information, it's actually throwing you many more questions. Unfortunately, I should also admit that after pan, you end up again taking another radiograph. So I would still question it's, so for me, pan is like this. It's there, it's nice and beautiful, but it doesn't take you anywhere really, right? So most pans are there. So now it's time to literally, if you haven't converted from being a pan lover to a 3D lover, I think it's really high time that we all started looking differently and start to look at 3D. Really high time you converted. So now let's look at 2D versus 3D and very, very quickly and tell you how wonderful this is. I'm sure at the end of these 3 slides, we'll begin to say, yeah, now it's time for 3D. Let's look at the typical, I'm sure all faculty in Shiravati Dental College, plus the practitioners who are, should I say, old time lovers of intraoral periapicals. I love my intraoral periapicals too. And this is what we generally hold every single day, right? You look at that, this patient complained of pain, the molar looks okay to me there. Okay, this was referred. So we had a look at the IOPAR. We had a look and the molar looks okay. I was wondering what's happened, saying, oh, the apex is cut off. Let's repeat. Those thoughts came in. But then we said, okay, let's take a CBCT. And then on the CBCT, you see these axial images. For now, let's call them axial. We haven't gone there still, but just to let you know, you see that nice fracture line, right? And here, the coronal going right through furcation area. You see the 3D reconstruction. And this was literally a fractured, a vertical fracture, right, involving the furcation area. This hardly showed us anything. I would have dismissed this of saying a little bit of bone loss. Let's see what we can do around our scaling, call him back, the typical routine that we follow. But then it's so important to go there to 3D. Let's look at this again. Referred from orthodontics. This boy wanted orthodontic treatment. I looked at the pan. Okay, saying tooth erupting. This okay can go ahead. The full complement of teeth present. Everything looked good to me. But then, at least in our dental school, it's a habit for the orthodontist to take a full FOV. Again, it's something called a low dose full FOV. We do that in orthoscan. And then, surprisingly, some things threw up. It threw up a lot of things. It showed us a tooth hiding there, right? Can you see on the axial section there? Nicely placed tooth towards the parietal cortical plate. See that there. And then I went back to my pan and say, oh yeah, something I see here now. I didn't pay attention to this as much because beyond the apices, it's very vague on a pan. It's a wonderful pan, but then they showed us something else. Otherwise, it should have just gone for routine orthodontic treatment. This is those typical films that we have all the time, right? Proximal caries that you see, and intraoral periapical, probably again, how should I say? I'm not finding faults with final year students or interns. The typical cone cut you get with a periapical fill. Wonderful proximal caries. Now a doubt on involving pulp, not involving pulp. So conservative dentistry would have a look at it. Then we thought, let's look at it on a CBCT. And then the picture changes like drastically. You have a big, nice radial CC there. You have the parietal cortical plate perforated. Around this root, you have radiolucency. It's totally a total different picture altogether. So that was all. If you didn't get converted by now, I think it's really high time. You have to move from 2D. Have to. There's no second thoughts. Because it's giving you so much more information. And why? Not because we want all that, because trust me, end of the day, it's going to help you plan treatment better. So outcome to the patient is much better. Now, for like I told you earlier, about 4 decades we had CT in place, and I also know some of my colleagues earlier before CBCT came in. Many of the practitioners would agree with me. When they were doing implant dentistry, it was with CTs. There's nothing else they could do, so CT was used. So let's try to compare, and let's see if it's really a good comparison or it's like comparing apples and oranges, totally two different things. So now we are now delving totally into 3D, and henceforth we'll move from here and then get into CBCT. So let's look at this fan beam, fan-shaped beam that the the CT has. So what the CT would do is to throw up a fan-shaped kind of a beam, and every single time it will go around the patient 360 degrees, gather all that information. Whereas what a CT would, what a CBCT would do is throw a cone beam, a beam in shape of a cone, and one-time interrogation. It's not happening multiple times. So you capture in a CBCT, you get that image in toto one time. Whereas in CT, there are multiple fan-shaped beams going all around the patient. Now this interrogation of the tissue, it just depends. 360 degrees is all the time with CT scan. The patient is in the couch and you have that integration with tissues. But most CBCT machines generally work with about 180 to 70 degrees. So sometimes we know of machines that go full 360, but most of them work with 188 to 70. So we had a look at this. Now this is just let you know what happens. In a CT, what would happen is you get these multiple axial slices. and then the software would integrate that to you and give you that final image. Okay, so that's what happens in a CT, and I tell you what's the big problem with that. Whereas in CBCT, what happens is you gather the volume first. Okay, get the volume, and then you have fidelity with the volume. You can actually manipulate those images in various planes. So you can slice them the way you want. You can do axial, you can do coronal, you can do any amount of slicing with the volume you have. Now you have enough amount of volume to play around with. And that's exactly what the software does. What was that big problem that I just mentioned about collecting all slices and then reconstructing like in a CT, or collect a volume and then slice them? When you collect in slices and make that a big volume like in CT, you have something called an isotropic voxel. What is anisotropic? It means in different planes, the image size is different. You don't get the typical image size. So you have these errors with regards to in a CT image. Whereas in CBCT, it's an isotropic voxel. It's what you see is what you get. So hence, that fidelity that you get, any amount of rotation, planes, do where you want, the size is not going to differ. It's not going to change at all. So that's the advantage of having CBCT, because it gives you those isotropic voxel. A small, should I say, just let you know, there's a point here. Though there's a lot of discussion of CBCT having those typical isotropic voxels, I'm very sure some of you already been using CBCTs, especially when you send out for implant planning and elsewhere. You get your reports, they tell you it's 2 mm away. When you explore, you say, hey, it's there in the canal, and these guys are telling me it's 2 mm away. It's really not, I should not totally blame somebody there, but you should know, though we call it isotropic, honestly, a lot of studies, especially in the last, should I say, 2-3 years, have thrown figures that have told us it's not really isotropic. There could be margins of errors. So it's sometimes, for all people who are already reporting, it's good to overestimate slightly than underestimate. That's the issue with isotropic and anisotropic voxels. I think the Xray generation we can just skip, just to let you know. Forget the CT, but just look at CBCT. They operate at 80 to 120 kV. And people who are working in colleges again, you know, the PAN is almost there. PAN also works around 88. You can actually vary the kV. So CBCT is just like a PAN. So it's easy for you to switch over. If you're ever working with PAN, it's nice to move to CBCT. Just work similarly. Also, just to let you know that CBCT systems work with something called a pulsed X-ray beam. It's not like a one shot. And why you should know that? It's just to let you know, with those people who have doubts, does CBCT cause a lot of radiation exposure? Not really, not as comparable to CT, because the X-ray beam is pulsed. So you have those gaps in between, there's no exposure. So that pulse exposure will ensure that the patient's radiation is low. Okay, just that small line for you to tell patients, to teach your colleagues, to convince them that CBCT is good. Just let's look at something called, for now, we don't know what is small and medium FOV because it's coming in the lecture, but just to let you know, when you use comparing between a CBCT and CT, it's like 13 to 82 microsieverts for a small or medium FOV. For the same site, if you had to look at a CT exposure, it's close to 470, 474, 1160 microsieverts. Like not at all comparable, right? The CBCT is hardly an exposure. So with this section, what we learned, we know CBCT has a cone-shaped beam. We use flat panel detectors. Very important, CBCT have isotropic voxels. I also want to put in here, we'll again repeat this a little later. When you use a small FOV, you have a better resolution. Definitely lower radiation dose than CT, right? That's all for now on this. That gets us to the third part of the lecture on what's CBCT ultimately, and guess you all are waiting for just this all this time. Right. So what's CBCT? I mean, we have these funny things that keep coming up. I just put up one there. Somebody wanted a CTBT of low rates. If I have to look at the CTBT, it reminds me of some people talking of RTC instead of RCT for teeth. So that's a funny thing there. So what's CBCT? So That's a wonderful statement to make. They said it's an advance in maxillofacial imaging since the introduction of panoramic. So from panoramic, CBC is now an advanced, the most advanced after panoramic. Okay, it's faster. Most importantly, fits into any dental practice. Very, very accessible to patients compared to going for a CT scan. We all know how difficult it is to just go for a CT scan of head and neck. So now we have a lot of migration of especially the maxillofacial surgeons sending us patients from CT scans to CBCT. But then a small point I'll make when I go to trauma. Right. So the concept of field of view, many of you must be aware, but just to let you know, when I say field of view, I'm just trying to say, what do I see? So we have people who refer, probably now with the new Vi-Scan that you have in Shivamogga, you will have patients coming with prescriptions. I would still prefer practitioners saying, hey, I want this area, rather than telling me I want a small FOV because it's priced cheaper. You should not say, I want medium FOV because it's cheaper than something else, or I want a small FOV because it's cheaper than a large FOV. So literally, I don't think you should go by the cost, but instead say, I want to look at the upper eight. I want to look at the maxillary sinus. Let the diagnostic center, let the dental school make that choice for you. But for you to understand right now, the smaller the volume, better is the resolution. I have also instances where dental practitioners have reported back saying, hey, it's not as clear. I wanted something else. I said, I'm sorry, you wanted a full FOV. Oh, he said, no, I didn't want a full FOV. I just wanted the upper six because I'm placing an implant. Then if it was the upper six for an implant, then you rather ask for a small FOV rather than saying, I want to see the whole skull. Now, what's the problem? One big problem of ordering large FOV is one, resolution is very poor. And let me give you the diagnostic center standpoint of view, since again, with small input for Vi-Scan, I'm sure they have more experience with so many centers already existing. But the big issue of asking for large FOVs, it becomes very necessary. It's in fact a part of ethics. It's also a legal requirement. Even if the dentist wants to see an upper six, if he asks for a large FOV, you need to talk about six plus every single thing you see on the large FOV. You cannot miss out a single thing. So that becomes a tedious process for the diagnostic centers, wasting a lot of manpower and time. Right. The concept of FOV now, based on the machine you have, that could vary. It could be a small FOV or a large. When you say small FOV, you're generally talking about that cylinder. What's the diameter of the cylinder I want to see, and what's the height of the cylinder I want to see? So are you saying I want to see the lower central incisor? I say I think you should go for a 5x5. I mean, all these machines come with different standard sizes. Or you say I want to see the upper and lower, I'll say maybe go for a 6 and 8. If I want to see, no, I want to see up to the third molars, I'll say probably go for a 8x12. And finally, if I say no, I want to see the skull, you go by 15x15. I mean, this could vary on, like I said, the FOV. And what this actually matches, it matches of the volume that's going to be captured. And this indirectly relates to the matrix I spoke to you a long time back, pixels and matrices. So the higher end machines generally have larger scan volumes. That's a takeaway message. But larger scan volumes mean nothing in terms of resolution. Yes, you give me that big picture, but I ultimately want to see that small tooth. So then go for a small FOV. Fine. When would I advise a CBCT? Mainly, very important, you all should know. You should have some diagnostic benefits. Just because there's a machine around, you will not be advising CBCTs. And when you advise CBCT, you should ensure that your clinical diagnosis is not enough. You need that extra adjunct to come in, and then you would ask for a CBCT. So looking at CBCTs, now the biggest challenge I heard from many of you with regards to, in fact, myself, is the lack of familiarity of this multiplanar imaging. I mean, we all used to seeing the 2D image, right? So suddenly we start to see things differently, right? So to get into it, what you would do is to start to understand with these terms of axial. We all know what is axial now. The blue image that on the left-hand side that you see, that axial plane. If it's front to back, you call it coronal, and side to side, you call it sagittal. So we'll start to use these terms now of axial, coronal, and sagittal. Right. I thought I'll spend a few minutes here on gross anatomic landmarks. I mean, this could go on and on this lecture, but I'll just briefly, I think this is the biggest challenge for many of us mappers rather. So I would suggest get to any anatomic landmarks book, get a picture, put it on your desktop. You could also, your diagnostic center would help you with all these. Many of them would mark landmarks if you want to. They could use that help. So if you have to go through these landmarks quickly, that's the frontal sinus for you. Look at the plane where I'm in. Now this is the axial section, right? So I'm going to work down from top to the bottom. And as dental surgeons, we are really experts of the mandible. There's nothing much to really choose from. But at the maxilla level, the mid face, there are some landmarks we all need to know. That's the sinus, the frontal bone is marked there. That's the temporal bone that you see, and the occipital. That's very simple. Now going further down, that gives you somewhere the level of the bridge of the nose. That's the nasal bone. So mid-facial fractures, the NOE region, this is where you'll be seeing. This is where you look for. That's the orbit, the superior orbital fissure coming there, the optic canal, and the temporal bone here, the clinoid process. Going down further, now things get a little difficult as we go to mid-face. The ethmoidal sinus, the intraorbital fissure. Now these are all sites where most of the postgraduate students would love to do their thesis on. So we get a lot of questions with regards to how exactly to interpret these things. That's the sphenoid sinus. Okay, temporal bone, occipital bone. Yeah, a few things here. The Vidian canal now. This Vidian canal again is very interesting. We get a lot of queries here. If you see that fellow here sitting there, that's the Vidian canal here. The Vidian canal mainly runs the Vidian artery and the vein, sorry, the nerve. And here we get a lot of questions from ENT surgeons, especially wanting to look at the Vidian canal. Any kind of inflammatory process here around the Vidian canal, especially in the deeper parts of the nose, patients have referred pain, very severe pain around there. So they look at this Vidian canal there. Going down further, you have the pterygoid plates. Again, this is again a very interesting site to look at the eustachian tube there. That comes the eustachian tube. The torus tubaris, that is where it's behind the eustachian tube here. Is again a familiar site with ENT surgeons who ask for referrals. The coronoid process. As we go down further, now you get familiar with the anatomy. Now it's very simple. This is the oropharynx. The center is the oropharynx. Okay, the styloid process now starts to slowly show up. So when we look at elongation of styloid process, we start beginning to look at these sections and down below. That's the oropharynx, the C1 vertebra. Here is when you begin to see the epiglottis, right in center of the oropharynx. Okay, that small shadow that you see there, that's the epiglottis right in the center there. Okay, and then that was the axial plane. You could do the same with the other planes too, right? I marked all of them. I'll not get in there, but let's try straight. This I would like to spend a couple of minutes here. Now it's so important. What we do is we love to just go through all the volumes, but what you should know is what do you look at each of the sections. So if somebody is asking for the oropharyngeal passage, it has to be the axial section. I'm not saying it cannot be seen other sections, but in the axial, it's a wonderful site to look at. Also the buccal and cortical plates, some kind of tumors, cysts, you would want to look at where the tooth is positioned, then you look at axial section. Fractures again, nice sites for the axial section. Pulp canal morphology, can you see that C-shaped kind of a canal there? So again, you can only appreciate this on an axial section. So you should know what to look at in each of those sections. Tooth positioning wonderfully seen in axial section. If you're looking at the poles of the condyle, especially condylar enlargement, osteochondromas, condylar head, you could see that on the axial sections. Well, the coronal sections are nice to look at the sinus and its association with teeth. You cannot see that well on axial. So if you're looking at some kind of a tooth fragment being pushed up the sinus, an oroantral fistula, some kind of a breach, then you'd want to look at it in the coronal sections. Of course, you could also do that in the sagittal if you want to. Right. Any kind of paranasal pathologies all around here, the turbinates, all that you get to see here on the coronal. Orbital fractures, wonderfully seen in coronal, especially when you're looking at something called a hanging drop sign or a trapdoor sign, where the orbital contents herniate into the maxillary sinus. You would want to look on the coronal. The sinuses can be really appreciated well on the coronal sections, especially the lateral and medial wall. Now going to sagittal. Now sagittal is almost this kind of view we are very familiar with because it's almost like our panoramic radiograph. So this is almost, should we call it the lateral view? You can actually see the lateral aspect of a lot of things. So this is again good view of the anterior posterior view. So this gives you this typical A is the condyle abutting against the glenoid fossa. Somebody wants to know, is there rubbing? Patient has degenerative osteoarthritis. I want to see what's the space gap between the condylar head and the glenoid fossa. Then this is wonderful to look at sagittal. Okay, you can see the incisive canal morphology. I mean, this would help with regards to implant placements. And yes, this one on the course of the inferior alveolar nerve canal. That's again made out well in sagittal sections. Now, a few minutes here with regards to multiplanar. Now, you should all know that what we had a look earlier were just landmarks, but then what you need to know is this multiplanar, and this is the biggest advantage when you start to look at CBCT. But you should be very familiar with anatomy. Just look at how the frontal sinus would behave in each of these sections. If you look at the axial, this is how the frontal will look at. On the sagittal, it's the configuration and then the coronal section. Similarly, each of these, you'd want to look at the nasal septum here. Let me go to something very unique. Infraorbital canal is there. The zygoma. Let's look at zygoma. Yeah, the nasopalatine canal. Okay, so on the axial, it's pretty round and yeah, you can see that configuration of the nasopalatine canal. But when it gets to the coronal, you begin to see it like a tunnel, right in the midline, somewhere there. So that's the nasopalatine canal. That's not a fracture line. And similarly here, you see right behind this incisor. That's how a nasopalatine canal would look like in the sagittal section. So this multiplanar images you have to get very used to, right? So that's again showing a model sinus. I can just skip this. I may have a lot of slides on how each one would look like. Now let's look at the coronoid process. We are so familiar with coronoid process on pan, right? And this is how the coronoid process would look like on coronal view. And then on the axial, it just looks like a small blib of bone of mass of bone there. That's the coronoid. And this would be the condyles. Right. Now let's look at how do we understand, interpret. Now, once you send out patients for imaging, normally the CT scan center would give you something like this, a report like this. Generally, I mean, the formats could change, but when the film is printed out, it's almost like how you would see a CT scan. What you would have to look at is, okay, what plane are they looking at, right? It's not just about, hey, patient, go get a CBCT. When it comes back, you should know what you're looking at, right? So when I get something like this, the first thing I'm looking at, okay, this is the plane he's talking about. The way this plane looks to me is, this is my coronal plane. Okay, he's saying section 1, 2, 3, 4. So I'll begin to say, okay, in the front, this is section 1. So this is at the apex of the central. This is how I'm looking at. As he starts to go more posteriorly, this is my last section. So this is how you would interpret, and this is giving you that reconstructed pan. That's what the machine gives you. And this is the plane. And they give you a 3D reconstruction saying this is, and you could actually some software called skimming the image. It could just mean removing a certain plane of tissue around the bone around, showing you deeper structures. Okay, you could give a skimmed image. That was coronal. Similarly, the same patient, somebody said, hey, look here, I'm giving you an axial section now with 4 sections, each of them marked really well. Can you see that lines there? 1, 2, 3, 4. So you know this is the sagittal plane, this is the axial plane in 4 levels. So this is 1, 2, 3, 4. So that's how you start to interpret. So you look at what level was a section taken, and then you get an understanding of what are you seeing.